We are live.
Welcome to today's iFocus online session, episode number 385 and Oculoplasty module number 60. So today we have the International Masterclass by Dr. Don Kikkawa on the medical and surgical management of thyroid eye disease and update. Dr. Don Kikkawa, he did his medical degree from St. Louis University School of Medicine, Missouri, residency at Jules Stein Eye Institute, fellowship in ophthalmic, plastic, and orbital surgery at the University of Wisconsin-Madison. Currently, he is the professor of clinical ophthalmology, chief of the Division of Ophthalmic, Plastic, and Reconstructive Surgery, and the vice chairman at the University of California at San Diego and Shiley Eye Institute, La Jolla. He has been the president in 2014, vice president in 2012, the president-elect in 2013 of the American Society of Ophthalmic, Plastic, and Reconstructive Surgery. He is the editorial board member of the OPRS and serves as scientific referee for several other important ophthalmology journals. And he has also delivered several lectures at the national and the international conferences, received several awards such as San Diego Magazine's Physicians of Exceptional Excellence, American Academy of Ophthalmology's Senior Achievement Award, the Marvin Quicker Thesis Award, the ASOPRS Research Award, and the Lester T. Jones Surgical Anatomy Award for the outstanding contribution to the ophthalmic, plastic, and reconstructive surgery. His clinical interests include aesthetic and reconstructive oculofacial surgery, orbital surgery, thyroid orbitopathy, craniofacial disorders, and tumors involving the orbit and the eyelids. We are very honored to have you in our session, sir. Thank you for joining. Over to you, sir.
Thank you very much for the kind introduction. It's an honor to be invited to speak, and I will be giving an update on thyroid eye disease. Good day to all of you. I know we're all in different time zones. Let me share my screen. Okay, well, thank you again for the kind introduction. We're going to get started. These are my disclosures. So I thought I'd first start by the conundrum we have with what we call this disease. It's been called many different things in the literature: Graves' orbitopathy, Graves' ophthalmopathy, Graves' eye disease, thyroid-related orbitopathy, thyroid-associated ophthalmopathy. And then the final one that appears to have stuck is called thyroid eye disease. And I also thought I would put the second slide up as to question who was the first to describe Graves' disease. I think this is a little bit of a trick question, but we'll go through the choices here. Was it von Bosedel? Was it Graves? Or was it Perry? So naturally, the trick answer would be number 2. But in fact, Graves was not the first one to describe the disease. It was actually described by Caleb Hillier Perry, who was an English physician, who in the 1700s noted an association between the goiter of the thyroid gland, the rapid heart rate, and the cardiovascular involvement. Well, how did Graves get this disease attached to his name? Well, he was the one who in the 1830s noted the eye involvement, and he was an Irish physician. And then von Bosedel was a German physician who characterized the disease, the weight loss, and the mental aspect of it. So in 1997, we started a thyroid eye center, and we actually collaborated with some colleagues in our department. You know, this thyroid eye disease is one of the few medical conditions that really transcends all of ophthalmology. You know, we see the oculoplastic specialists involved, we see strabismus specialists, we see neuro-ophthalmology. We also can sometimes involve our glaucoma and cornea colleagues. So it really transcends a lot of the different subspecialties. So back almost, 30 years ago, we started this eye center. And what it did was we allowed all of our patients to come into a central intake session. So new patients were examined in a joint setting where we had all of our specialists seeing the patient for the first time. We found that this really improved our communication of patients, the management, the coordinated care, made it easier for patients rather than coming to see multiple physicians. They came one time, we decided on a treatment plan, and it also helped us with our research. There are now many collaborative groups across the globe. UGOGO is the European group on Graves' orbitopathy. There's the International Thyroid Eye Disease Society, and then there are several U.S. university-based centers, not only at UCSD, but at Michigan, Minnesota, Stanford, and Mayo. Let's first start by defining what thyroid disease is not. So many times we see patients come in and they look very much like this patient on the right, and they think, gee, my thyroid gland is causing this eye problem. But in fact, we have to tell them, no, it's not really the gland causing the eye disease. It's really your immune system that attacks not only the gland and the eyes, but there are two other target tissues that sometimes we don't see very frequently. One is the pretibial myxedema on the upper right, and the bottom is the thyroid acropathy that occurs in the periosteum of the joints of the hand. The epidemiology shows that it follows, like many other autoimmune diseases, it's mainly a female predominant disease with a 6-to-1 ratio. Smoking is thought to be not causal, but patients who smoke definitely have a worsening of the eye problems. And then about 20% of patients who have the diagnosis of the eye disease will at some point experience some eye involvement. Now, we will see that this could be very mild or it could be very severe. What are the typical signs? Well, eyelid retraction is the most specific sign that is present, meaning that if that's negative, patients don't have eyelid retraction, then you really have to question whether or not they have the disease. So this is where you see the upper eyelid pull up above the corneoscleral limbus. In this particular patient, we have an MRD of +8. And in fact, George Bartley, who published a very large epidemiologic study at the Mayo Clinic, showed that if this sign is not present, you must look for a thyroid abnormality as well as some other cause for this condition. So this is a very specific sign. Proptosis is probably the number 2 thing that we see. Don't confuse that with lid retraction. This patient happens to have both, but sometimes we see proptosis on an absolute level without the lid retraction. And recall that proptosis readings can vary between gender as well as ethnicity. The upper limits of normal, probably in the patient base that we see, is probably about 20 to 21. So anything higher than that is kind of an absolute elevation. Strabismus can also manifest itself. Typically, we see the inferior rectus muscle and the medial rectus muscle is the most commonly involved. However, the superior and lateral can also be involved, as well as the oblique muscles. But most commonly, the inferior is seen in this patient here. And it can also be very asymmetric. That's the other thing that we really have puzzled explanation for, is that why would an autoimmune disease really affect just one eye? Sometimes we see delayed involvement of the other eye, but about 10% of patients who have an asymmetry with their findings. And also recall that because of the very tight aspect that these muscles have, the intraocular pressure can rise. So this can be typically seen when patients look up. In fact, if we see a greater than 5 millimeter rise, that can be suggestive of a tight inferior rectus, indicating possible thyroid eye disease. Optic nerve dysfunction can occur in severe cases. Typically, this is from orbital apex crowding. It can be caused by apical compression on the optic nerve. Sometimes you do see disc swelling if it's more anterior, but posteriorly, sometimes we don't see disc swelling at all. And then we may see color desaturation, particularly red is, as you know, very sensitive for that, as well as visual field changes. And this indicates a more urgent need for intervention. Exophthalmometry is the way we measure proptosis. There are different methods. This happens to be a Hertel exophthalmometer, which is based on the lateral orbital rim. I try and do mine as repeatable as possible, and sometimes you'll see variation between different observers. Try to keep the same base, as well as make sure the pressure that you place the exophthalmometer is also fairly consistent. And I try to just make a mental note of myself and make it as repeatable as possible. But certainly as you change the base and you change the amount of pressure that's applied, you can certainly get a false reading. So if you look at the slide on the right here, you see this patient has, the hash marks line up with the anterior corneal surface. This is about an 18 measurement. Let's talk a little bit about the pathophysiology. So there was some very pioneering work by Terry Smith, an endocrinologist, who discovered that the thyroid eye disease appears to be driven by co-localized receptors, cellular receptors of the IGF-1, which is located in green in this box, and the thyroid stimulating hormone receptor. So antibodies will bind at both sites, and they drive this complex intracellular process that involves hyaluronic acid production, glycosaminoglycan production, which causes deposition of ground substance into the cells in the orbit, as well as adipogenesis. So there appears to be two different arms that this autoimmune process drives. You can also see on the upper left side of this box that the activated T cells and B cells also produce interleukins, which cause inflammation. So the cascade of the intracellular process appears to be driven a lot by the IGF-1 receptor co-localized with the thyrotropin receptor. We do see some differing phenotypes of this disease. So these are two papers that I'd like to maybe just highlight of how this disease presents. So the first one that thought that maybe these we're seeing a different spectrum of disease was the paper on top back in 1993 by Bill Nunnery. So just recall with the previous slide, we spoke about how the pathophysiology is driven into two different mechanisms. So think about each of these processes being predominant. So in a predominantly adipogenic variety, you're going to see much different than you would see in the glycosaminoglycans. And then Jimmy Uden followed up Nunnery's paper with several different other phenotypes. But the main type of spectrum that we see appears to be what Nunnery called type 1 disease, which is the top row of photos. As you can see, this patient has fairly white eyes. There's really minimal inflammation. On imaging, because this is mainly the adipogenic variety, you don't see large muscles. And then on the coronal scan, you'll see more fat infiltration. The muscles appear to be relatively normal in size. Contrast that with the bottom row of photos. This is primarily the myogenic variety, where you see the glycosaminoglycans being deposited into the muscles. This draws in water. It's hydrophilic, so you can see the muscles are very large. There also appears to be more inflammation. Some of this may be congestion. As the muscles enlarge, it does reduce the venous outflow of the orbit, so you could get some congestion in the vessels. And then you see that this on coronal scan, the muscles are much larger in size. So these are two ends of the spectrum. Both CT and MRI are useful. Obviously, in certain clinical scenarios, one may be more important than the other. I used to almost exclusively get CT scans when I was first in practice because it was mainly for surgical planning. So we would want to see the bony orbit and the relationship of the sinuses. But I've almost exclusively switched now to MRI as my first choice of imaging. The reason is because we see a little bit more detail of the muscles. You can see the fat suppression images. You can actually look and see if there is inflammation in the muscle itself. And then you might ask, well, gee, if you end up operating on these patients, you have to go back and get a CT. I've actually gotten pretty good at operating on the MRI. So it's almost like processing, we used to do photography with negatives and positives. So the MRI, as you can see, if you look at the bone on the MRI, it's dark, but it still represents the same kind of more wider bone on the CT. So, you know, I think it's something that I've at least tried to switch in my own practice, is to rely exclusively more on MRIs rather than CTs. Obviously, of course, some patients can't sit in the scanner. They may be claustrophobic. They might have metal implants. So not everyone is able to have an MRI. Let's chat a little bit more about this type 1 versus type 2 disease. So again, we talked about this being, these are two extremes. So this is one end of the spectrum, type 1, where we see fat infiltration, and then type 2, we see predominantly muscle involvement. We did a study looking at what we call fat muscle ratio. So rather than being, you know, strictly a type 1, type 2 binary decision, we actually looked at this as a ratio, where we would look at the cross-sectional area of each of the muscles. We would add that up, and then we would divide that by the total orbital volume. So the calculation that we did was looking at adding up the muscles, which we see on the bottom left, and then we actually added we took the total orbit, which is seen on this right side of the slide, and then we subtracted the muscles, which left the fat volume. So this fat area was then divided by the sum of the muscles. So this was a ratio that we used to calculate, rather than just thinking in our mind, well, this looks like type 1, this looks like type 2. Sometimes they're in the middle and we can't really tell what they are. But this is a way of defining kind of what the ratio of the fat to muscles is. And what we kind of found out was that after looking at about 40 patients, there really is a normal distribution. So obviously the type 1 patient would be on the type 2 patient would be on the left. So this would be a low fat to muscle ratio, where the orbit is primarily filled with the large muscles, versus the type 1 variety, which is a high fat muscle ratio, being on the right side. And the middle part of this ratio is about 1.3 or so, or excuse me, 2.3. So why is this important? Well, in reality, I guess we just show that there's a spectrum involvement, not necessarily a binary phenomenon. In general, the fat predominant patients tend to be younger. In general, the muscle predominant patients tend to be older. And then this can lead somewhat to how we predict treatment effects. So let's talk a little bit about Rundle's curve. So Rundle was a general surgeon who described this disease activity curve, and Rundle thought that initially deterioration occurred, patients became stable, and then in general there was some improvement over time. So I think we see many biologic processes. In fact, many things in life in general follow Rundle's curve. There's could be, in fact, some people have described some stock prices to follow Rundle's curve. So it's not just a biologic phenomenon. Things get worse, they stabilize, or think about any sort of disease process, and then maybe there's a little bit of improvement. So in general, we used to think that Rundle's curve was kind of this time course that we would follow. And the thought was that medical therapy was better for the front part of the curve. When patients were stable, we followed them. And then in general, if we were to offer surgery, would do this kind of in the green area or the improved state. You never want to operate on someone if they're still changing, particularly if your main goal is proptosis reduction, because they may get better on their own. Certainly, we can do surgery in this earlier phase if patients have optic neuropathy. Let's talk a little bit about grading classifications. So we do need to all be on the same level as how we describe patients, but don't confuse disease activity versus disease severity. Patients can have very active disease and not be very severe, or conversely, they can have very severe disease and not be very active. The clinical activity score is the most widely cited and used, but it may not be applicable in all scenarios. VISA was described by Rootman and Dolman in 2006. There's the UGOGO scale, and there's the American Thyroid Association Severity Scale. So let's touch briefly on how we talk about these patients. So CAS, or Clinical Activity Score, is divided up into 7 points or features on the initial visit. So 2 of the questions deal with pain. Do patients have orbital pain, spontaneous pain, meaning do their eyes hurt or feel uncomfortable at rest? They would get 1 point. If their eyes are uncomfortable when they move their eyes, that's a 2nd point. A 3rd point could be gained for eyelid swelling. If you look at this patient in the photo, the lids are swollen, so that's an additional point. Eyelid erythema, look at the color of the eyelid. Do they appear erythematous? Yes, that's another point. Conjunctival redness or injection. This patient has engorged vessels. Chemosis, which this patient also has. And then inflammation of the plica, which is this inner, the plica semilunaris. So this patient actually has a 7 out of 7. Please note that 2 of the points can be obtained subjectively, which means that this is probably not a 100% correlative scale that we can use for every patient. You know, the sensation of pain or pressure varies between patients. You know, the other 5 points are objective that the physician will grade, but 2 points can be obtained subjectively by the patient telling you, yeah, my eyes hurt all the time, or yeah, they hurt when they move. So it's not a perfect scale. The VISA scale attempted to incorporate some other aspects. So VISA stands for vision. For the V, I is inflammation, which includes a lot of the CAS elements we just spoke about. S is strabismus. A is appearance. And then the total score for this was 20. So, you know, vision, if you look at the vision, it was basically whether or not patients had optic neuropathy or no optic neuropathy. Inflammation was very similar to what we just talked about with the CAS score. Strabismus was basically looking at the restriction of the extraocular muscles. So greater than 45-degree movement would be 0. If they had restriction to within 15 degrees, that would be 3 points. And then the appearance was based on the amount of proptosis, lid retraction. And then these were all added up. And then you could see with the sub-grade score here at the bottom, you could probably a little bit more accurately track whether patients were active or not active. Just briefly, 2 other scales, severity scales. There's the UGOGO scale, which looked at mild thyroid eye disease patients that had minimal lid retraction, minimal exophthalmos. UGOGO actually grouped moderate and severe into one class. The second class, which had greater than 2 millimeters retraction or greater than 3 millimeters of proptosis. And then the third category is the vision threatening or the optic neuropathy or corneal breakdown issues. A 4th severity scale was the American Thyroid Association. They have 4 categories: mild, moderate, severe, and sight-threatening. So just bear in mind that UGOGO grouped moderate and severe together for only 3 categories. So, you know, I think in our own minds, we all know what mild, moderate, and severe TED are. For research purposes and communicating amongst ourselves, it may be good if we use some standard measures so we can accurately describe patients to each other. So bear in mind, no grading scale is perfect. Subjectivity is part of the grading scale. There are some inconsistencies between the ATA and UGOGO scales we just looked at. I think for our own practice, it's important for us to be objective and consistent. Let's move a little bit now on to treatment. So there is an overall staged approach where we certainly use supportive care initially, and then we do follow the standard practice of medical treatment first, followed by surgery. Things have changed a lot recently in terms of how I treat patients, but in general, who should get medical therapy? Typically, we reserve this for more inflamed patients, so CAS score 4. Do the symptoms affect their daily living? Are they having problems with pain, pressure, diplopia? And then do they feel like they have disfigurement? Do we need to provide something for proptosis reduction? Some of the prior questions about medical therapy mainly just focused on whether or not they altered the endpoint of disease. A lot of these patients were started on oral steroids, and sure, they look better, but when the steroids are tapered off, it really didn't change the endpoint. And you could even question, does this hasten the inflammatory phase, or does it prolong it? Because as you taper patients off the steroids, sometimes the inflammation kick back up. I think the goals for any treatment should be that we restore the pre-disease state. So that's the gold standard. We look at photos of how patients looked before their eye disease started, and we compare them. And then we certainly want to reduce the symptoms of inflammation. Many of us don't deal with chronic pain, but those that do, it really weighs on you on a daily basis. So just think if you have constant pressure or discomfort, retrobulbar ache, that really causes some major impact on patients' lives. And then certainly the disfigurement is something that, again, we do see patients that have social stigma. They withdraw from their social circles. They don't work. So we really have to try and do our best to help them from that perspective. Well, what are the common supportive care elements that we offer patients? Well, certainly ocular lubricants are useful. Smoking, we encourage all patients who come in smoking to stop smoking. In fact, I've had several patients that have been smokers, and I basically have said, well, I'm not going to do any treatment until you stop smoking, because you're just going to create a situation where we might make some improvements, but you're doing something that harms yourself. So please stop smoking. We refer them, if necessary, for professional help with smoking cessation. Stress reduction, so there's no doubt that stress plays some role on the immune system. So we encourage patients to get mental health counseling if needed. And then selenium has been shown in mild cases to be effective in the 100 microgram BID dose, but really not that useful for more moderate to severe cases. Well, the standard, very traditional approach has been to treat patients with IV steroids for severe inflammatory disease. So IV pulse steroids is probably a little bit more efficacious and less harmful than oral steroids, because the IV is usually done in a pulsed fashion. There are varying protocols. And the one that I tend to use more frequently is the 500 weekly for 6 doses. Be aware that there are side effects, potential side effects. There can be liver toxicity. There have been some cases of patient demise from the liver toxicity. Usually this is dose dependent. Anything over about 8 grams has been shown with a higher risk of patient mortality. So just be very cognizant when you prescribe it. It is effective in reducing. This is a patient on the right side of the slide showing fair amount of inflammation initially, and there the patient is after 3 infusions of pulsed IV steroids. Radiation has been used for optic neuropathy, inflammatory disease, and strabismus. It is somewhat controversial. Some patients some studies have shown benefit where others have not. The typical dose is about 2,000 centigrade. And then there have been some studies that show that there's no need for both medical therapy or radiation, and they're not necessarily additive. They can be used kind of complementary to each other. We talked a little bit about this earlier. There's certainly a mood disturbance. This is a patient who sent in photos, and you can see that as the disease progresses, that the disfigurement is something that is very difficult to deal with, and patients do tend to withdraw from social circles, and it affects their mental health. We looked at a study of our patients, and we concluded that the psychological burden can be severe. And although none of us have any background in mental health, we need to refer our patients if they show any sign that this impacts their mental health. In general, we've talked briefly about some of the broad categories of drugs for autoimmune diseases, but if you look at them, they're typically 4 classes. There's the nonsteroidals, there's the steroids we talked about, Cytotoxic agents have been used in thyroid eye disease, and then there's the biologic response modifiers or the genetically engineered monoclonal antibodies. From a historical perspective, cytotoxic agents have been used, azathioprine, methotrexate, with varying degrees. There was a study that showed that mycophenolate had some greater effect than steroids alone, and that was published about in 2018 in Lancet. And then there's the biologic therapy, which really, in my opinion, has really helped dramatically to improve our treatment of these patients. There have been three main ones that have been utilized. The top two are off-label in the US. So rituximab was used extensively in Europe. Some studies did show CAS reduction. And then there's tocilizumab, which is an anti-IL-6, also off-label here in the US and has shown effectiveness to reduce CAS. And certainly there's the FDA-approved product, which is teprotumumab, which we will be speaking on shortly. So getting back to the pathophysiology slide that I showed earlier, Terry Smith was very instrumental in discovering this molecule. So the IGF receptor is located on the orbital fibroblasts. And the thought is that if you block this green IGF-1 receptor, you will also block this downstream cascade. So in January 2020, teprotumumab became FDA approved, and it's given through IV infusion over 8 cycles. And then subsequently, what we see is we see the reduction in the muscle mass as well as some of the adipogenic stimulus being reduced. So this is just a little bit closer up magnification view. On the left side of the slide here, we see that the TSR, the autoantibody, and the IGF-1 antibody, autoantibody stimulate the surface of the cell. And then in green here, the teprotumumab comes in and blocks the IGF-1R autoantibody, and that reduces the downstream cascade. So if we look at the driver of the disfigurement and the discomfort being proptosis, in the past, we've had surgery as the main way to reduce proptosis. But our thinking now is that with the advent of teprotumumab and its FDA approval, this allows what we call a medical decompression. So we get proptosis reduction from a medical process. And in the past, I think if you look at steroids and perhaps some of the other antimetabolites, we really didn't see the proptosis reduction so much with those agents. They were primarily geared for the anti-inflammatory aspect. So let's talk a little bit briefly about surgery. So surgery is a way to reduce the proptosis. We explain it in different ways to patients. Just think about the orbit as a box. What we do with surgery, we move the walls out, we make the box bigger. That allows the orbital soft tissues to expand and reduce the proptosis. Sometimes there may be the induction of secondary strabismus. Patients also may have pre-existing strabismus, but as the muscles shift, they may cause a deviation in the effect of that one muscle, so they may need a second strabismus procedure. And then the last procedure would be eyelid surgery. Sometimes from start to finish, this could take up to 9 months to a year to get all the procedures done. So sometimes that also weighs on patients with their treatment burden. But other than disease prevention, surgery used to be one of the only ways that we could restore the disease state. I'd like to walk you through this patient that had all 3 steps of surgery. So this is the patient, how they presented on the left side. The patient had optic neuropathy, recurred after IV pulse steroids. You can see there's a massive amount of chemosis and exposure. Here is the patient on the right after undergoing a 3-wall decompression. And you can see that the proptosis is better. However, there was the inducement of a large angle esotropia. Incidentally, I don't necessarily, when I talk to patients about this and I say they might get diplopia, I usually say that this is not a complication of the surgery. This is a known side effect. When we create space, the muscles shift and the eye may come off position. It doesn't mean the surgery was not successful. It doesn't mean the surgery was complicated. It's a known side effect that as the muscles pull differently, the eye can come off alignment. Here's the patient pre-strabismus surgery on the left and post-strabismus surgery on the right. You might ask, why did the patient get lid retraction? Well, recall if you recess the inferior rectus is attached to the lower eyelid retractors. So as the inferior rectus gets moved back, it can also pull the lid down. So this was the patient who was orthophoric after surgery and now has lower lid retraction. And here's the patient after undergoing lower lid retraction repair to correct the lower lid lower lids that retracted after the strabismus surgery. So here's the patient from start to finish after stage surgery. So, you know, we got pretty good at the surgery in terms of the results. I think this patient had an excellent result. But if we could avoid surgery, it would be all the better for the patient. Another patient before and after decompression showing the targeted areas of bone. So the green area is the lateral wall that we would burr down. The blue shaded area is the medial wall. The red represents the posterior orbital floor. And then this yellow shaded area along the rim. So these are all areas of bone that we would target in a maximal decompression. Patient before and after surgery, as you can see, we got pretty good at the results. So let's shift now. At least I think we're seeing in our practice that we are discussing the use of teprotumumab as primary therapy before we even consider surgery. So I'd like to show you an example of 3 cases that we've treated with teprotumumab. One followed the phase 2 and phase 3 clinical trials very closely with acute thyroid eye disease. The second is what we call chronic disease, where think about that right side of Rundle's curve, where the patient was further out from their initial disease treatment. And then there's the last patient, which is very puzzling because this is decades outside of the traditional therapeutic window, but still the patient had active thyroid eye disease. So this is a patient who had presented with 6 months of swollen, puffy eyelids. He experienced diplopia on extreme gaze. He did have hyperthyroidism from Graves' disease, and he had radioactive iodine and had really done well for many, many years, and only recently had developed the eye findings. He stopped smoking about 10 years ago. You can see on imaging, he has large inferior, medial, superior rectus, even maybe his superior oblique is a little bit enlarged. Here's the patient pre-treatment. His visual acuity was 20/20. His CAS was judged to be 4. He had exophthalmometry readings of 22. Here he is after 8 infusions of teprotumumab. His CAS score reduced to 0. He had a 3 millimeter proptosis reduction. He did have some side effect of cramping. So you can see this is what we would refer to as a pretty good medical decompression from teprotumumab. Second patient I'd like to share with you, we published in the American Journal of Case Report, American Journal of Ophthalmology Case Reports, co-authored by Dr. Ozello, Dr. Korn. So this is a 50-year-old female who had a 3-year history of Graves. She had 2 years of stable proptosis measurements, very asymmetric. She was 28 on the left eye, 23 on the right eye, and she had a CAS score 1, primarily attributable to retrobulbar pain. This might have been a patient that we'd have taken to surgery in the past, but the patient had comorbidities, was not able to have surgery, so we did infuse her with teprotumumab. This is just after 3 infusions. So you can see the muscles have reduced in size. The proptosis reduced about 6 millimeters in the left eye. She did have fatigue, which resolved. So we felt compelled that this was such a interesting case that we published the case after just 3 infusions. He continued to do well after having all 8 infusions. The last case I'm going to show you is a patient, an 81-year-old, who had orbital decompression 25 years ago. So she really has been dealing with this thyroid eye disease for a good part of her life. She still presents with painful, bulging eyes. You can see she has inflammation on her conjunctiva and the caruncle. Her CAS score was 4. Her exophthalmometry reading were 30. She did not want further surgery. She was otherwise healthy. Again, had been dealing with this for a large portion of her life. Here is her imaging. What we see is large muscles. We see the inferior, we see the medial. You can also argue that the prior decompression that was performed elsewhere was not done properly. She has bilateral maxillary sinusitis, probably from occlusion of her osteomeatal complex. The medial wall also probably has some space that we could give her. But again, she was not interested in further surgery. She underwent 8 infusions of teprotumumab. Her exophthalmometry reduced to 25, so she had a 5 millimeter reduction. She did have some side effects of cramping. Her glucose elevated slightly to 150, and then we did monitor her audiogram, which was stable. So some of the potential side effects of teprotumumab, as we mentioned, elevated glucose, that needs to be monitored. So we usually check a fasting glucose with every infusion. Patients that have diabetes need to be co-managed with their endocrinologists. Muscle cramping is also seen in fairly high frequency. Typically, it's cramping in the calf and the thigh. It usually occurs around the infusion sites, infusion times, and so typically in the first couple of days after infusion. Malaise has been described. It can be teratogenic in childbearing women. They should be on contraception. And then hearing impairment is probably the one that has received the most attention recently. It occurs in about probably 7 to 10% of patients. Typically, what we see is several symptoms can occur. One could be tinnitus, so they start to hear ringing in the ears, muffled hearing. They could also hear their voice more in a higher tone, which is called autophony. And then the sensorineural hearing has also been described. Most of the cases that I've treated have improved after cessation. However, there are some longer-term cases in the literature. Another thing we've noticed with teprotumumab is, in contrast to decompression, is that with decompression, which is on the top side of the slide here, before and after, you can see that because you're creating some space for these muscles, sometimes the muscles enlarge. So if you look at the slide left on the top row, the lateral rectus, the inferior rectus, which are outlined with the white circle, after decompression got a lot larger. In contrast, what we see with teprotumumab on the bottom row of photos, look at the left orbit on the coronal scan. You can see large muscles pre-treatment, and then these muscles reduce in size. This is also correlated with the amount of stiffness that is seen at the time of muscle surgery. So our strabismus surgeon, Dr. Granite, this is somewhat anecdotal, but he has commented that the teprotumumab treated muscles are much more pliable and are able to have a little bit more resilience with their surgery, as opposed to very stiff, non-compliant muscles that are seen in patients such as the top one with the scan, with the large muscles that are very scarred. So is surgery still needed, I guess, is the question. In my practice, I would say yes. This is a study we looked at where we looked at the pre-teprotumumab group as a control, and then we re-examined our surgical numbers in the teprotumumab era. And what we saw was that both groups were relatively the same, but the amount of decompression dropped off significantly. So we probably saw about a 60% reduction. So the control group, the pre-teprotumumab on the far right column, showed that we did about 23 in the study period, as opposed to 8 in the teprotumumab period. A different way of looking at the data was our hospital records a CPT code for all of our decompressions. So the CPT code is 67445 here. So every year you can see we were from 2016 to 2019, we were pretty constant with our lateral wall decompressions, and then 2020, 2021, 2022, we saw a drop off. You could argue that years 2020 and 2021 were from the pandemic, but we still see a reduction even in 2022. So what are the types of patients that still need treatment post-teprotumumab? This is a patient here who had some reduction of proptosis with the teprotumumab, but still wanted further treatment because she still felt her eyes were not as recessed as they were pre-disease state. Here she is post-decompression. You can see that there has been an improvement from both the teprotumumab and the surgery. And I think that it has allowed us to do less surgery. So where we might have done a 3-wall initially, sometimes we're doing less, maybe just a lateral wall and fat. Well, what about lid retraction? It's not too well studied. My clinical impression is that when the proptosis reduction improves, the lid retraction also improves. Patients may still need lid retraction repair, but if you see the lid retraction without the proptosis, I think you get less of a effect of the teprotumumab. So this is the patient pre and post treatment showing an improvement in lid retraction. And this is a patient here who on the upper left underwent teprotumumab. You can see improvement in proptosis. In the middle portion, she's still complaining of lid retraction, and here she is on the bottom right. So in future directions, what do we see as the need for this disease? Well, we don't have a good handle on biomarkers and disease predictors. So there are some biomarkers, TRAb levels, TSI levels can be somewhat correlated with disease activity and severity, but they're certainly not 100% correlated. So we do need better markers. There may be development of new targeted therapies. So because of the success of teprotumumab, there are a myriad of clinical trials now going on in the US. Some of these look at different IGF-1 antibodies. There's IL-6, IL-11, and then there's the FcRn that are also potential new avenues for treatment. There may be a need for combined therapy. Some of these therapies could be developed over the years so that it's not just solo therapy. And then I think there still is a need for continued surgical development. Image navigation certainly is a way that we can offer better care to patients. I kind of think of teprotumumab as the penicillin of the antibiotic era. It was the first. It's very successful. And it may be such that it still is used, but there probably will be improvements along the way. So in summary, thyroid eye disease is a very challenging autoimmune disease with several extrathyroid targets. Clinical activity should be monitored by at least one of the scoring systems. Just be consistent in your own practice. Medical therapy is effective in reducing inflammation. And now we do have the means to achieve proptosis reduction in addition to surgical means by targeted biological therapy. So thank you very much. I think we're pretty close on time. I'm going to stop sharing my screen and I will take any questions.
Thank you so much, sir. That was really insightful on the recent management of thyroid eye disease. A lot of things which we had heard of, but not really gone into depths, which you covered beautifully for us. We do have a few questions. In continuation for what you said about teprotumumab, when do we really consider it and what should be the follow-up protocol for such patients?
Yeah, I think it's a very good question. Initially, I think we didn't have much experience about prescribing biologics. So we thought, well, should we involve our rheumatology colleagues or endocrinology colleagues? But the side effect profile for treatment is actually favorable. So the immediate infusion reactions are fairly minimal. I think I've had one call in over 100 patients that we've treated that said, well, yeah, they had an infusion reaction. So it's not like other chemotherapy agents where you have to be very careful and monitored in an infusion setting. But that being said, we do consider it first line now for inflamed patients that have a high disease burden, and then we will check them after the first infusion. We do get baseline audiogram on every patient. So the hearing issue is the one that people are worried about. So we check a baseline audiogram, And then with any symptoms that occur, we repeat it. So I see patients after the first infusion, just check in, see if there's any problems. Then I'll check them one more time mid-treatment and then at the end. So probably 3 visits over the 6-month period.
Okay. The next question is, what is the role of endoscopic decompression in thyroid eye disease, sir?
Yeah, that's a good question also. So decompression can be performed by any means. You know, the ENT sinus surgeons are very adept at endoscopic sinus surgery, and many of the oculoplastic surgeons here do partner with ENT. I think there are some oculoplastic surgeons that perform endoscopic sinus surgery on their own. I do endoscopic DCR. I have not made the jump to endoscopic decompression because I feel more comfortable through the transorbital approach. But I think it is certainly a viable option. And I think if you have a good sinus surgeon that you work with, or you're adept enough to learn endoscopic sinus surgery on your own, I think it's certainly a good option.
Okay. What is the maximum dose of rituximab that we can give while we are treating the patients? Is there a cutoff value?
I don't have a lot of experience with rituximab. I think I might have treated 1 or 2 patients off label many years ago. I was not impressed with the clinical response. So now that is rituximab has what they call a black box warning here in the US, meaning that there can be serious side effects, particularly I think the black box warning here is the inducement of what they call progressive multifocal leukoencephalopathy from slow viruses that could occur. So that is a medication that I do not feel comfortable prescribing. So I would involve our rheumatologist for rituximab.
Okay. In a patient with the TED who has underwent maximum dose of steroids, received immunomodulators, also undergone a decompressive surgery, if they come back with the reactivation of the disease, then how do we go about treating them?
Yes, that's a difficult conundrum. I would say here we would give them teprotumumab, but I don't know if you have that. I don't think you have that available there. I would consider maybe one of the off-label biologics. Tocilizumab, I think might be a good option. But yeah, if you've exhausted all means, typically what we see with the reactivations are not as bad. Sometimes you can kind of get them through the little reactivation that they have, maybe with some oral steroids. I think peribulbar steroids are also a good option. I didn't cover that at all in my talk, but local administered 20 milligrams of triamcinolone can be very effective. So local injectable steroids in the orbit. Okay.
Is there any difference in treating a pediatric thyroid eye disease and an adult thyroid eye disease, or is it similar?
Yeah, no, I think it is different. I think the youngest patient I saw probably was a 4-year-old that had thyroid eye disease. So, typically the sinuses are not well involved. So they're typically not a surgical candidate until they reach adult, adolescent age. I think if you have to do something, I certainly would not give them teprotumumab either. That is contraindicated. Typically, they're the fat adipogenic variant in younger patients, so you don't necessarily get the explosive inflammatory onset. They can be still bothered by the lid retraction. I think if I were to do anything, I certainly would delay treatment as much as possible and observe the patient. And then if they develop any sort of issues, I certainly would hold off on decompression. I would hold off on teprotumumab. Maybe consider eyelid retraction repair if the patient had very, high MRD or had symptomatic corneal exposure. But I would probably try and observe as much as possible.
Okay. So you mentioned about the fat muscle ratio. So how exactly does it help in the treatment of TED?
Yes, so we published another paper that I did not discuss. We found that the low fat muscle ratio, so if they're mainly muscle, they respond better to teprotumumab. So the large muscles, as I think I showed on many of my CT scans, responds quite well to teprotumumab. The adipogenic variety, the high fat, responds, but not as good as the large muscle. So it's somewhat of a predictor for the response to teprotumumab.
Okay, and the last question is, why does smoking cause worsening in thyroid eye disease? Why that one particular thing to stay away from?
Yeah, it's not just the nicotine, because we obviously have vaping now, which you can get the nicotine without the smoke. It's the smoke. Yeah, so it appears to be the smoke is toxic and causes increases the inflammation of the orbit.
Okay. Thank you so much, sir. That was a really good end to the day for all of us. It was a lot of information covered in a brief period of time. A lot to learn from you, sir. Thank you so much for joining us.
Well, thank you very much for the invitation. Wish all of you a good evening.
Thank you, sir. A gentle reminder to all of you regarding our National Postgraduate Education Program, iFocus Offline, which will be conducted on June 9th to June 16th of 2024. This year, we're conducting this at Hyderabad. There are going to be wonderful sessions, both didactic and hands-on sessions. The registration is limited to only 300 candidates. So please book in your seats early. There are concessions for early registration and it closes soon. The registration is available online and the ID is given below. Also, about the next class, we'll be having the next class on International MasterClass on inherited eyelid, lacrimal, and orbital conditions. This will be conducted on the March 8th by Dr. Richard Allen from US. A wonderful night to all of you. Thank you for joining us.